So as I mentioned, today's session is managing anger and aggression in children and adolescents. Our presenters are Dr. Kylie Schneider, who is a clinical child postdoctoral fellow here at the University of Texas at Tyler Health Science Center. Dr. Schneider received her bachelor's degree in psychology and child development from Texas Christian University and went on to earn her master's and PsyD in clinical psychology at Baylor University before completing her training here at UT Tyler Health Science Center. Dr. Schneider has worked with children and adolescents and their caregivers in community clinics, residential treatment centers, inpatient hospitals, and academic medical centers. And Dr. Schneider is now faculty and an assistant professor here at the university, so we're pretty excited about that. And she also is teaching behavioral management and neurodevelopmental and disruptive behavior disorders. Elizabeth Hooker, who is a part of our team here at UT Tyler, joined the University of Texas at Tyler as a behavioral health specialist back in September 2020 when we actually went live. So Elizabeth joined us as we built our program. Elizabeth is a native of Louisiana, having completed her undergrad and graduate education in counseling at Louisiana Tech University in Ruston, Louisiana, and moved to Texas in 2018. So she got here as soon as she could. While attending Louisiana Tech, she earned her graduate certification in dynamics of domestic and family violence, and she is recognized as a nationally certified counselor by the National Board of Certified Counselors and is trained in EMDR, that's eye movement desensitization and reprocessing. While working in Louisiana, she spent time with clients in the drug court system. Since her arrival in Texas, she has worked as a crisis counselor, providing therapy services for child and adolescent survivors of domestic violence and sexual assault, and I can tell you that that's a passion area of hers. She really enjoys working here with the CPAN and PeriPAN team, using her therapist skills to help primary care providers identify the most appropriate non-pharmacologic therapy for their young patients with mental health needs, and also educating them on trauma. And I can tell you that she's also passionate about perinatal mental health and will be taking some training along with the rest of our team here shortly, early in 2024. So I'm going to go ahead and turn this over to Dr. Schneider. Dr. Schneider, do you have your PowerPoint up and ready to share?
Yes, I believe so. Let's see.
And we are seeing your screen that has the objective.
The presenter view?
Yeah.
Gotcha. Right, let me try a different setting.
It's always kind of a crapshoot.
I know, I never know the right button.
Well, this is a session that there's quite a bit of interest in. We have 69 on our session today, y'all.
So no pressure.
Right. Let's see.
Joel said F5.
Yes. Let's see.
And I'll have to remember that.
F5, okay.
And we are recording this session, so just be aware that we will be placing this on our YouTube page for the University of Texas at Tyler Health Science Center, hopefully by the end of the business day. If not, I'll have it posted tomorrow. That way, if you'd like to go back and take a look at that information, it will be available for you.
Okay. So sorry, y'all. I thought
it's okay.
Let's see. And that's doing it again.
It is. Do you want me to go ahead and show it on my screen?
Sure. Yeah, if you don't mind, I apologize.
Not a problem. Let me pull that up. It'll take me just a minute because we do have the session. I appreciate y'all being patient with us here.
So sorry about that. It was not giving me the present in Teams option. So I'd like to pretend I understand technology and then
It is all good. And I just have to get back to the share my screen. Okay, can you see my screen correctly?
Yes, ma'am. Perfect. Thank you so much.
Mhm.
Okay, well, thank you all so much for joining us today. We're very excited to get to chat on this topic. We know that anger and aggression can be a intimidating thing to help families handle, and so we're happy to share some information with you today. Okay, we can go to objectives. Awesome. So our objectives are as stated on the flyer. We're really going to focus on introducing some of the clinical terminology and kind of picking those hairs apart on what um, anger and aggression look like. We're also going to talk about maybe some of the diagnostic classifications that you might see on kiddos charts or you might want to consider. Then we'll really spend a good chunk of time talking about different interventions, both that involve referrals to secondary care or that um, involve those referrals to secondary care, or maybe some things you could actually do in the office. And throughout this presentation, we'll focus on a case example to get to practice these skills. Okay. So first, we're going to talk about understanding anger and aggression, and I'm going to pass it over to Elizabeth to talk about terminology around those ideas.
Thank you. And I'm just gonna say I have whatever creeping crud is going around, so my voice is a little sketchy and I do have coughing fits, so I'll mute if I have a coughing fit. So I'll just go ahead and apologize for that. So this is a list of terms and labels that we both have heard used in the clinic setting. I would like y'all to take a moment and think about how these terms can actually pigeonhole a child, especially if it's in their chart. And remember, their charts follow them around. So that language that you use for a 5-year-old may actually follow them until they're 18, 20, 30. And how or is this language actually meeting the needs of the child? So next slide, please. So diving into some of the terminology. So again, remember that anger is a feeling or emotion. And when I look at anger, I kind of look, when I'm working with a client, I look at the 3 different types of anger. So there's passive anger, which many people don't like to admit that they are angry because they don't want to be confrontational. This is called passive aggression, and it comes out, for example, like being silent when you're angry or you're sulking or you're procrastinating on that project because that staff member really ticked you off and you don't want to do it. You're going to put things or projects off that you need to do, pretending like everything is fine. I am guilty of that when people say, "Oh, are you okay?" No, I'm fine. It's fine. And then passive aggression comes from the need to be in control, and that control is being taken away from you. So that's something to remember. Open aggression. This is when, and this is in children, teens, and adults, they have the tendency to lash out in anger or in rage. They'll become physically or verbally aggressive, and they can oftentimes hurt themselves or others. It comes out as fighting, bullying, blackmail, accusing, shouting, bickering. Sarcasm is a huge one that a lot of people will miss, and criticism. So sometimes anger can be taken out on property and on themselves or others. So if they're self-harming or if they're throwing things, that kind of stuff. And then there's assertive anger. This is an alternative way of dealing with anger, and it's having the self-control and confidence to talk, to listen, to be open, to help dealing with the situation. One second, I am sorry. Snuck up on me there. Um, and with this, it's understanding, this is when teenagers or children start understanding others' feelings, so they start having that compassion. And this is when a child or adolescent will learn how to deal with their anger, and they can demonstrate it in a mature and caring manner. So they'll still have the anger outbursts, but they're able to reason and they're able to communicate. The next one is aggression. So this is the behavior or action that can be hostile, destructive, or violent. And this is more of the physical aspect. So you're throwing things, you're doing property damage, you're having harming, whether it's to themselves or others kind of behavior. A tantrum, this is usually as a result of frustration for not being able to do, have, or to avoid something. So with children, with toddlers, it's more of a communication skill. They can't communicate what is wrong because they don't have the they don't have the language skills just yet. So if they don't know how to communicate, they get frustrated, they throw a tantrum because they get the attention that way. ODD, this is a pattern of anger, frustration, mood. They might have some argumental or defiant behavior, and this lasts 6 months. And they'll have irritability, anger, and mood. They might have argumental or defiant behavior. Those are the two things to look out for, and especially if it's going on for at least 6 months. And then destructive behavior is when a child has threatened or intimidate others, or they violate the social norms. So this isn't a communication, this isn't a frustration thing. They are actually violating social norms because there is something going on. Next slide, please.
Okay, so yeah, I love how Elizabeth kind of separates the difference between that anger and aggression, right? Anger is more of the emotional state, whereas that aggression is the behaviors that we often see. And that can be important in kind of clarifying with our kids and our diagnostic pictures of which part of that is going on. So here we're talking about the different diagnostic considerations that can come in when we're looking at anger and aggression. Anxiety is kind of the unexpected one that kind of catches people off guard. Oftentimes irritability and that aggression or aggressive behaviors could be part of the fight or flight response that occurs in kiddos. It's called fight or flight for a reason, right? So if I'm anxious enough, if I'm dysregulated enough, and truly if my body is sending me skills that I'm in danger, I definitely might act out in an aggressive or in an anger focused way. Depression and mood disorders also come in here. Irritability is usually a core symptom for depressive disorders in childhood. So actually clinically, sometimes we're looking for sad or low mood, but we might also see some of that irritability in there. Adjustment disorders can also be a really common space. So adjustment disorders are usually considered when a kiddo has gone through a pretty significant stressful event or stressful kind of life change within the past 3 to 6 months. Boys are more likely to present with irritability when we're looking at adjustment disorders, but it can definitely happen across the gender norm. Mood altering states are also something to consider, right? So a little bit outside of the diagnostic picture, but also, kind of like we talked about with adjustment disorders, wanting to consider those environmental stressors, what new changes or significant life events have happened. Have there been any changes to routine or structural events that might be causing them to kind of have that fight or flight response? As well as other actually cognitive or mood altering substances or states. So again, substance use, anger, and aggression can absolutely come alongside of that, especially if we're having a negative reaction to that substance or that drug. Early psychosis, while very rare in younger kiddos, can definitely present with some aggression, irritability, some of maybe that oppositional behavior like Elizabeth was talking about. Kind of in line with those last couple points that Elizabeth was showing, we can also have our defiant and disruptive behavior disorders. So this is a cluster of disorders that actually involve that idea of those oppositional, those defiant, or those disruptive behaviors, where they're actively arguing, actively showing some physical or verbal aggression, or maybe even going a little bit beyond and breaking some more significant social norms. Anger, irritable mood, and aggression are all part of the clinical picture. This usually occurs in about 3 to 5% of kiddos. This is including oppositional defiant disorder, and then kind of the more severe presentation of conduct disorder. these diagnoses are twice as likely in male patients and become more likely as they age. Trauma disorders is also the one that I think was historically less recognized for involving anger and aggression, but I think as our knowledge of trauma and trauma presentations is improving, it's becoming more well known that similar to anxiety, that irritability, that anger, or maybe even verbal and physical aggression can be as a response of that fight or flight in relation to some of those trauma reminders that can come up or the different hypervigilance symptoms. And lastly, we have our neurodevelopmental disorders. So this is including our kiddos who present with ADHD, with autism spectrum disorder, intellectual disabilities, or maybe specific learning disabilities. Their frustration with the dissonance between maybe their age, their social demands, and what they're actually able to do can be really frustrating. So a kiddo with ADHD might really struggle socially or in the classroom, but they know they should be doing something different, and so they become very angry or aggressive. Or with a learning disability, if a kiddo is overall pretty intelligent, but really struggles with math, let's say, to the point of having a learning disability, then sometimes we can see anger and aggression come out in the math classroom as a response to some of the emotions they're having related to not being able to function the way they want to or the way they're expected. And then with some of our kiddos who have more sensory processing needs, you can also see some of that overstimulation come in. I think a lot of times anger and then aggression are secondary emotions because it's a lot easier to be angry than it is to be sad or worried. And so we can see that come out, especially in our kiddos who maybe don't have the emotional intelligence of an adult or maybe to their developmental level. And so I think that's why we can see it a lot. Okay, next slide.
So we wanted to put this one in just so that you guys can look at the physical well-being versus the diet and nutrition about sleep and how sleep hygiene is so important when dealing with kiddos, teenagers, and adults. So with the physical well-being, if they're if it's noisy in the bedroom, if there's a lot of light coming in, if the temperature of the room, if there's a fan going on. One case that I had, it actually dealt with the fan, and I thought that was kind of interesting, just because they had a little bit of ringing in their ear. So when it was really, really quiet, they could not sleep. If they couldn't sleep, they'd be really, really, really grouchy in the morning. So parents turned on a box fan, and the child was able to sleep better, and that helped with the aggression a lot. So it's little things like that, looking at the child's environment, see if it's conducive to a good night's sleep. I'm sure that everybody has their ritual that they use when they go to bed. For example, sound machine, they have to have the fan on, they have to have a certain blanket, that kind of stuff. Another thing to look at is dinner time. Are they having a Coke with dinner? Is that adding caffeine to their diet when they're supposed to be kind of starting to calm down a little bit, ready for bed? If they have this jolt of caffeine, they're not going to be ready for bed at 7 or 6. Another thing is vitamins. I had a couple of parents who would give their kiddos vitamins and supplements at dinner, and one of them was B12, B6, and B12 will have a little bit of caffeine in it, and it will the kiddo would not sleep. So they changed it so they would give them in the morning, all their supplements in the morning, and that helped with that. Let's see. There are a couple other things. So disclaimer, I'm not a doctor, I'm not a nutritionist. So I don't claim to be that, but understanding that, if the kid are they going to bed hungry or are they waking up hungry? That will also mess with their sleep as well. So, but I really like this, especially if you give it to parents, just so that they can have some ideas about, temperature of the bedroom, making sure it's conducive to good sleep hygiene. Next slide, please. Okay, so this is another great sheet that I would give parents, and this chart is great to use when talking to parents when they're looking at anger in a quote unquote normal setting versus other challenges that the child may be experiencing that have not been addressed. So as when we were talking about earlier about the learning challenges, are they, do they actually have a ADHD, or do they have dyslexia or something like that that is getting them upset in the school setting because they're not on the same page as their peers. So they are getting angry, they're getting frustrated. So, having an evaluation done so the child actually receives the support that they need is a good first step. And you want to do this, you know, as early as possible. If you have an inkling of anything, trust your gut and say, okay, let's get them in an evaluation. Let's see if we can get this going so that they can have the support, so they can start building on that support. Having support when they're going in first, second grade versus seventh grade is going to have a huge impact on both their, mental well-being and having those supports in place. So that you don't have any argument from the school or anything like that. Next slide, please.
Okay, so this is our case example that we're going to talk through. I'm going to read it out loud, and then I have some questions that y'all feel free to put some responses in the chat. So Jack is a 10-year-old male who just started the 5th grade. He presents to his doctor's office with his mother to establish care because they just moved into the area a couple months ago. Jack's mother states that he has always been an energetic kid. However, at his new school, his teachers have been complaining that Jack lashes out in class when he is asked to transition between tasks. He lashes out when he's completing work independently or staying in his seat, or when he's asked to do these things. He's also pretty aggressive with his peers during recess. So what are some features that you note that feel consistent with anger or aggression in Jack? The move and the change in school, absolutely. Yeah. So that would definitely be some of the psychosocial factors of, he just had this big transition, he's adjusting to a new space. Yeah, so the lashing out, yeah, an adjustment differential, absolutely. Aggressive at recess, yep, that would be part of it. Yeah, all of his routines are disrupted. He's really thrown off and trying to establish some new stuff. Maybe some untreated ADHD. Yeah, his trouble with peers are a sign. Absolutely. Thank you all so much. So yeah, we're noticing that he's kind of having these lashing out at demands or requests by adults, having this aggression with peers, and maybe just this hyper arousal with the energetic child piece, right? And so I saw y'all hit on some important things that maybe it's related to his routine disruption, his move, adjusting to a new space, and definitely I think maybe an adjustment differential or ADHD being part of the clinical picture. 100%. Awesome. Thanks, y'all. So keep Jack in mind as we kind of move through the second half of the presentation, because we're going to be speaking a little bit more on what you can do as providers within the primary care office. So we can keep Jack in mind. Okay, next slide. Yes, so next we're going to talk about interventions. Okay, next slide. So just some quick information that I think it can be important to think about or challenge your families to think about with their kiddos. Obviously, if a kiddo is coming with established diagnoses, we want to take those into account, right? I kind of talk with families about a can't versus a won't behavior. So there are things that our kiddos won't do, like I actively refuse to clean up my toys because I don't want to, I'd rather watch TV. Or there are things our kiddos can't do, such as I'm too dysregulated, I'm overstimulated, I don't have the mental or physical capacity to do these things. It makes me think of, I heard when I was going to get my dog trained, of a mother was frustrated with her child because he wasn't letting the dog out enough, and so the dog wasn't getting potty trained, but the child was 4 years old. So that's a can't behavior for that kiddo. That's not a won't. So maturity also comes into play, and there can be a difference between our developmental age and our chronological age. So just because our Jack is 10 doesn't necessarily mean that his developmental age is 10. There can be a lot of factors that interact with that, such as, his existing diagnoses, his history, the type of modeling and social exposure he's had. So maturity level is definitely important. We don't always want to fit intervention to the chronological age. Trauma can be a really big factor, and I think that's true of any diagnoses that can come into play. We want to make sure that we're answering the need of the behavior, right? All of our kiddos' behaviors are asking for something. And so we want to make sure that our treatments are answering what they're asking for. And so the type of diagnosis, or honestly, this kind of consideration, if it is a trauma presentation or anxiety presentation is really important to know. Birth order can be important. There is some research to say that maybe aggression increases down the birth order, but I think it is more important in the fact that we think about what our kiddos are seeing and what they're modeling. And so sometimes our target kiddo or the kiddo in our office isn't necessarily presenting with any significant diagnoses, but if they have family members who are, maybe we're modeling, that can be important. And then thinking about the social environment, which I think we've kind of hit on in some ways. Yeah, kids do well when they can. I love that. Thinking about our kiddos' environment, again, the modeling, the level of demand that is being placed on them. Sometimes we see a lot more behavior in school than at home because school is just a lot more demanding in a lot of different ways. Or maybe vice versa. Maybe home is way more stringent and school is not. So watching for that as well and watching for differences across settings. And then we just want to think about those developmental age ranges, right? And we think about levels of regulation when we think about this. So again, typically in our early childhood, kiddos are more experiencing other regulation. So kiddos in this stage are going to have a really, really hard time doing anything on their own. They're really going to need adults and caregivers to talk to them about their feelings, connect their feelings with skills that they can utilize, or even connect their feelings with what's going on. Oh, your puzzle wasn't working the way you wanted it to, and you feel mad, helping build that bridge and really kind of doing the regulating for them. When we get to middle childhood, they're starting to develop a little bit more of a solid emotional awareness. They're kind of having a desire to be more independent and identify independently. And so we might help them more with like catching the anger before it gets too big, or kind of giving them cues to regulate after we've introduced some good skills. And then in adolescence, usually they're much better at facilitating their own regulation. Caregivers can be more of a safe space to explore their regulation and kind of what's bringing up emotions. And so we want to be prepared to help support their autonomy and independence in regulating, while also knowing that sometimes we may have to help cue and facilitate the regulation. Okay, next slide. So my favorite recommendation of all is understanding the function of our anger or the function of our aggression, right? And I think we've kind of alluded to this and, understanding the difference of diagnosis. I think Elizabeth hits on this in her example with her sleep kiddo, right? Understanding what behavior is trying to accomplish, either consciously or unconsciously, is very, very important. So an ABC chart is a really thing to introduce to families. We essentially want to describe it on behaviors don't happen for no reason, or very rarely do they happen for no reason. What we want to understand is what is the situation where behavior usually occurs? What are the usual flavors of that behavior? And then what are the usual responses? And what are the usual functions? So we challenge families to think about the activating event, the behavior, and then the consequence. And from that consequence, we can really find the function. So a chart like this, where you just kind of hand it to a family and say, okay, for the next month, what I'm going to ask you to do is record behaviors. So notice the W's, the who, when, where's. So who is around, where are you, what time of day is it happening? And then identify an activating event. So not necessarily the trigger, although it can be, but even just challenging them if a behavior feels like it comes out of nowhere, just saying, okay, so just label what was going on at that time. It doesn't necessarily have to feel like the thing that caused it, but what was that kiddo doing in that moment? Then really being specific about defining behavior, right? Saying a kid fell out is a great descriptor, and a lot of people understand what that means, but that doesn't really give us the actionable things that are happening, or it really doesn't tell us how severe, how long it happens. So getting them to kind of record the behaviors as well. And then have them record the consequences. How do people respond? Because oftentimes the consequence is telling us more about the function. So if you'll notice on the left-hand part of the slide, there's that little blue square there, that talks about the functions of behavior. So sometimes a function is access. So in order to obtain a tangible item, so I have a 2.5-year-old. Yesterday morning, he woke up and said, I want a cookie for breakfast. And I was like, ooh, bud, cookies aren't necessarily one of our breakfast foods. And then he cried and he was having a hard time because he was hoping to get me to give in and give him the cookie. Or not hoping, but that was the function of that behavior, right? He wanted to access that. Sometimes when our kids hit, throw, push, it can be related to access, right? We can see that on, oh, I'm just really driven to get the thing I want, so I'm going to push it out of the way. Sometimes it's to avoid either a task or a demand, or maybe just a stimulus that we don't really like. That also kind of goes into the automatic. But sometimes we just want to avoid. It's a chore I don't like to do, and I'm hoping if I throw a big enough fit, I'll get sent to my room and I don't have to do it. Behaviors like that. Attention, good or bad. And I even like to use the word connection. So our kiddos are looking for connection with us. And they will follow the path of least resistance. So if most of the connection our kiddos are getting from us come from negative spaces, the no, stop, don'ts, then they're going to gravitate towards those more. The behavior that we reinforce is the behavior that happens more, and our attention is really reinforcing. So that's why I like to ask, how did someone respond to that behavior? Because if the response is, I'm orienting, I'm talking to you, I'm paying attention to you, then that's giving that kiddo that connection, even though it's coming from a negative space. And then automatic can be, again, either to gain sensory input or to avoid sensory input. And that can sometimes function, again, on more of that reflex automatic space. Knowing the differences between what function the behavior is trying to do, what is the behavior trying to access, to gain, is really important, because that changes how we respond to it. So that's why an ABC system is a very important first step for assessing behavior and being able to tailor intervention. Okay, next slide.
So this is another great handout that I like to give to clients, and actually have it up in my office so that I can remember to do it for myself with my 1-year-old. Especially for de-escalating the situation with a child. So the key takeaway is you want to identify, you want to get on the child's level, so get eye level. So that means, take a knee, take a chair, however, that way they get that reaction from you, and then support them. Because again, it might be a communication thing. It might be that they're overstimulated. They need help self-regulating. And as a parent, that is their job, is to help them self-regulate. And, there's boundaries that are important to understand, that set limits. Sometimes that can be difficult for parents, but understanding that they're going to have boundaries, and, understanding that they can agree or disagree with what the kiddo is doing. Sometimes a cookie for breakfast is okay. Sometimes it's not. But having those boundaries with the child and communicating with the child. This is also great for teenagers too. So I like it because it's very, very well-rounded. Next slide.
Okay, so kind of the main intervention that we would think is most helpful for providers to introduce in the office is really surrounding around emotional awareness, right? And some more practical reinforcement skills that can be introduced. But emotional awareness is the first step. If I have no bodily or cognitive awareness of the emotions that I'm having, then it's going to feel like I go 0 to 100, and behavior is going to escalate before I even understand that I need to stop myself or I need to do something about it. So helping caregivers develop cues with their kiddos for emotion. And this kind of goes along with emotion identification tools, which is what's displayed here. So there's kind of two different ways of doing it, right? An emotion chart is always super functional. The younger a kiddo is on their developmental level, you're going to have less emotions available. Like I have a 25 square emotion chart in my office, which can be overstimulating to some kiddos, especially when they're just beginning to understand their emotions. So helping a family have that conversation of, okay, what are the 3 to 5 main emotions that we have? Let kiddo put it into their own words, and then have those down so they're visually available, like one of these examples, for kiddo to see and respond to. Developing cues is part of that, right? So caregivers and kiddos can kind of collaborate on what is the cue, what is the signal that tells me I need to check in with myself? Because sometimes me as the kid, I have a harder time noticing when I'm starting to escalate, but my caregiver might notice. So, I think we can all relate to being a little reactive if someone tells us we just need to calm down, right? And so this kind of gets in the way of some of that early conflict of just, it's a previously established word of like, hey, check your chart, or hey, check in, something like that to cue kid that, hey, take an evaluation of what's going on. And that's where feelings thermometers can be really helpful. So that wheel there is just some basic identification. It uses it heavily relies on visual cues to kind of tell kiddo, hey, when you're sad, you might cry, or when you're mad, your eyebrows might furrow and your cheeks might get red. Whereas a feelings thermometer is going to really target intensity of emotion. You can do one kind of more general, or you can do one specific to an emotion, where you have kiddo identify what are the physical symptoms and emotional cues and physical cues that you're experiencing at different levels. And then even going the step further, if a family is available or ready to, of pairing specific calm down skills to it. But the big part of emotion identification and developing cues is to help them identify, okay, here is the level of feeling that I'm at. And here is, kind of noticing the breaking point. So maybe on this thermometer, when I get to orange, now it's going to start to go off the rails. So that's a point where I need to bring in someone else to help me regulate, as opposed to just doing it on my own. And so helping families facilitate that conversation. Modeling and practice of positive behaviors is also a really important one. I want to note real quick, Rachel had put in the chat the University of Washington's resources. They are fantastic. They do have a lot of things available there, both for providers and for families, but they can help with these education tools, right? Because we're trying to keep in mind that, let's say you only have 3 to 5 minutes to coach a family on this. You kind of want to be able to talk them through it and be able to explain it in as few words as possible. And so those handouts can definitely help support that. So when we talk to a family about modeling and practicing positive behavior, it's essentially having the communication with the family of being willing to model effective behavior for your kiddo is a really great thing. It does not show that, you're maybe being too vulnerable or you're trying to be their friend. It's actually showing them that you're a person too. And the more that we do, the more our kids will do. So being able to do that, setting up times to practice. So saying, hey, we're going to set 10 minutes in the house. So we're going to take a special trip to the store where we're going to practice our regulated behavior. And then kiddos get a lot of that immediate praise for the good behaviors that they're doing. Again, practicing that emotional labeling. So kind of like we talked about earlier of just, again, caregivers being comfortable with trying to label their kids' emotions, or if we get it wrong, letting kid correct us, and labeling their own emotions as well. Or even as you're watching TV with your kid or reading a book with your kid, labeling the emotions that you're seeing in the situations and helping them build the connection between the situation and the emotion and then the response. And then even moving into behavior charts, right? So again, if we're thinking about building positive attention towards desired behaviors, we can help kiddos identify like, okay, when I take a deep breath when I'm mad, or when I count to 10, or when I catch myself when I'm about to curse, even starting there, and setting up reinforcement for that. It can encourage kids towards regulatory behaviors as opposed to just telling them they need to be good. We want to give them credit for the thing that's really hard to do. And then if we need to refer our kids to higher level services, like with a therapist or a psychologist, these are some of the interventions that are often really helpful and the things that we can instruct parents to look for. Cognitive behavioral therapy, dialectical behavioral therapy, especially for our teens, parent management training, which is usually and can happen throughout childhood and adolescence, but can be really focused on our younger kiddos. Trauma-focused cognitive behavioral therapy, if trauma is part of the picture, or even just social skills training for our more neurodevelopmentally driven kiddos who are having that harder time with the social skills, and maybe that's driving the anger. Okay, next slide.
So there are a few different activities that PCPs can give to parents to help the child relax and regulate themselves. It's also great for parents to have for themselves so they can regulate their behavior. I know when my 1-year-old is playing with the toilet paper, um, I have to calm myself down because that's a trigger for me because he will run it and then the cats will play with it and the dog will play with it and it looks like it snowed in my house. I have to stop and take a couple deep breaths and say, okay, cool. He's going to help me pick it up. It'll be all right. So it's good to kind of remind the parents that sometimes they themselves need to regulate, and the parent management therapy is a great way to teach parents how to do that. Um, these are also really good for staff too, for dealing with the aftermath of a stressful parent or a patient or a phone call. And I really like the grounding, different ways of grounding, and then breathing. So if they are, getting really, really, really tight, finding a way to kind of relax themselves and getting into that habit so that it's second nature. Distracting them, taking a couple of deep breaths or doing this box breathing, which I really, really like. That way it's both of a tactile and a visual calm down method. So you're doing a bunch of different sensations if they're going to trace the arrows and do that box breathing. Um, and then understanding, when I'm angry, I love the middle one because it looks at, okay, do they need to do deep breathing? Does that work for that child? Or do they need to physically get that energy out? Because some children, they like the breathing. Others, they like to like shake it out and stomp their feet or do something with that energy. Talking to parents about having a calm down corner in their household. So it's a special chair, it's a box of toys, having something to fidget with. That way they can get that energy out while they're dealing with their breathing, while they are self regulating. So that way they can practice and, try to master it. So I really like having these kind of cubes in a little basket or having a squish ball or something like that. That way they can get their frustration out, regulate themselves, do their breathing, and make that into a habit. So and also identifying what are your anger triggers, what are something that happens to your body or to your thinking, or if your thinking patterns change when you start to escalate. For example, I know when my 1-year-old or my husband or a client is starting to get angry, they might tense their fists, they might start getting tight, they might start getting red. So if the client or the patient can start identifying those, then they can say, oh, wait, I'm starting to get angry. What's going on? Do I feel uncomfortable? Is it a control thing? Is it fight, flight, or freeze starting to come in? So they can actually take a step back and say, okay, I don't want to have this anger. I need to figure out what's going on. Start regulating so it doesn't turn into a tantrum or it doesn't turn into aggression. Next slide, please.
Yes, and I'll build on Elizabeth's statement as well. What works so well about those recommendations that we showed and that Elizabeth was talking about is that they're really focusing on the body and helping the body regulate before the mind. Because when we do reach a certain level of emotional arousal, our thinking brain turns off and our alarm brain turns on. And so we really need to help regulate the body before we can have a conversation about what even happened. I think that's sometimes the pitfall we fall into. We want to talk about it like, hey, it's not that big of a deal. Calm down. Listen, we can talk about it. We can figure it out. Your toy just broke. Your boyfriend just broke up with you. It's not that big. But our kiddos aren't in that headspace. Their bodies are too hyper aroused, or their mind has gone blank, whatever is going on. And so grounding and physical response techniques really help bring them back to things that are really well known, which has a calming effect. I kind of like default back onto things I know, as well as helping the brain regulate the body and all of those HPA axis responses that are going on. I thought about on the slide with observing. being able to do a color search with a kiddo. Again, a little bit younger of a strategy, and you can elevate it with older kiddos by doing more of like a sensory search. If any of y'all have heard of like a 5, 4, 3, 2, 1 skill, but a color search is just, hey, find something in the room that is red, that is orange, that is yellow, and kind of walking them through something familiar, but also grounding in the space. When those skills aren't working though, when crisis kind of comes up, that's when we can really look into how do we plan for that in the office. So establishing safety plans and crisis protocols ahead of time are really important. You don't want to get stuck in a situation where things have gone awry and you don't have a plan in place. So I'd really encourage that amongst your staff. I know this plan is an individual safety plan, but even talking about crises that have happened in the clinic before, what have been the typical behaviors, the typical triggers, the things that work, and kind of walking through these steps as well with your own plan. Review them regularly so that you know them before situations occur and really know your options. Know what is available as far as what police or security response can happen, where your closest ER is, who you have on staff who maybe has training in de-escalation or behavioral health situations so that they can help assist in those situations. And practice whatever your organization recommends if containment or more physical intervention is necessary. Obviously, you can always use crisis services when they're available. I know here in Tyler, we have some crisis numbers through the Andrews Center and other organizations. And so again, could be another Google to figure out what's available. And then if you have a kiddo who is kind of often presenting with some more aggressive or destructive behavior, you could always make a more individual safety plan with them. And make that with them, and knowing that if that safety plan doesn't work and the strategies that you don't work, that may mean that we're calling in outside individuals to help support us. Okay, next slide.
So these are some mental health apps that we came across. Some are free, some have subscriptions. Calm is a really, really good one for sleep, especially for teenagers. For kind of if you have that anxiety, Mind Shift and Hapfy is great. Mind Shift is free. Yeah, Mind Shift is free, and it's more of a cognitive behavioral. So it gives you that little bit of therapy. It is not therapy, but it has some therapeutic-like information in there. I really, really like it. I Breathe is great for stress, and it does that self-regulation for your breathing. I'll give that to clients when I was working at the crisis center. And then Headspace is a good one for like meditation and just kind of getting, if you find that clients are kind of in that thought tornado that turns into an anger tornado, or anxiety or depression. These are all great for kind of the anger, the anxiety, and the depression symptoms. So if you've got anybody, they're multi-purpose, you can use them for anything. Overall, Mood Kick is great. It is $6 a month, and it kind of has a little bit of everything. So again, we wanted to incorporate some free ones and then some that have subscriptions to them. But if you wanted to find something just so that you can start somewhere, definitely give these a look at. And then we have some related services. T-Chat is great for the education. So this is more for teachers and in schools. So if the parents have questions about that, they're welcome to call CPAN. We can give them a little bit of information and get them the numbers that they need to connect. CPAN and Peripan, of course, is what we do. And then there's YAM, which is, again, more towards the teacher school system. And then there's, outpatient therapy and psychiatry, psychology, if needed, for the kiddo, adult, or adolescent. So it just kind of depends on what their needs are and how you want to do service for them. Next slide.
Okay, so what are kind of the takeaways for PCPs and other medical providers when we're thinking about managing anger and aggression in the office? The top thing is just gaining as much information as you can to help inform recommendations, right? We want to understand frequency, intensity, Everything on that ABC chart, right? People, location, time of day, function of behavior and consequences. So how are people responding? And what other diagnoses that are going on? Also, just what I call the history, and kind of like Elizabeth mentioned, what medications are they on? What is their sleep like? Is their diet and times of eating like? Really focusing on what can precipitate these behaviors and what are they getting out of these behaviors to help understand it. And so that comes into helping parents learn how to track these behaviors on an ABC chart, and learning how to start to notice those things, because you're only going to get a small snippet in the office. And if a family hasn't really even been attending to those things, they might not know. So challenging them and helping them learn how to track those things so they can bring that information to you next time can really guide recommendations. Providing those resources to help families get connected when it's appropriate and if it doesn't feel manageable within your office. Again, to things like counseling, maybe further assessment, or if you think it's related to a learning difficulty, referring to special education or an emotional difficulty. Those are also addressed in special education services. And then again, kind of like we talked about with some of those emotional awareness and regulatory skills, provide those brief educational interventions in office. Practice them with colleagues on what's your 3 to 5 minute elevator pitch for this skill. There are links some provided. We have some other recommendations as well that can really help support passing on the sales pitch of that education. Next slide. Okay, so we're back to Jack. What are some recommendations that you would have for Jack? What are some things that you would want to suggest to his mom as she's sitting there in your office? Or even, is there anything you want to learn more about first before offering interventions? Emotional identification. Yeah, absolutely. We want to help Jack get a little bit more awareness around what's going on. Address the sleep. Yeah, I think sleep is a really focusing on, their within depression work, we talk about the PLEASE acronym. So it's really focusing on physical illness, sleep, eating, alcohol and drugs, exercise, really focusing on those body things. Yeah, ask him to keep a log. I love that. I think that's a great recommendation. He is 10 years old. If he has the cognitive capacity for that, I think that's wonderful. Yeah, understanding why they moved and is that a stressor related event? Understanding the antecedents. Vanderbilt's, I love measurement-based care. That's wonderful. Yeah, getting a little bit more information on that clinical presentation. Yeah, understanding, again, kind of that precipitating the before and after behavior. And then, yeah, understanding home a little bit more in family history. 100%. Awesome, guys. Next slide. So, yeah, when we're looking at those practical applications that we can think about if we want to teach Jack and his mom anything in the office, that ABC chart, both for mom and Jack, and maybe teacher, if teacher has the space for it, on what's going on with that aggression, increasing his emotional awareness, maybe have an emotion wheel, or even if he's ready to understand intensity of emotion, go to that thermometer. Go to those great regulation skills that Elizabeth talked about, that deep breathing, that muscle tensing and relaxing that comes with PMR, and maybe some grounding exercises he can use in the classroom that might not feel too disruptive. And then if needed, refer towards mental health services. So cognitive behavioral therapy for Jack, maybe some parent management that involves mom, if a lot of these behaviors are also happening in the home, some social skills training to help him with those peers on the playground, and then potentially psychiatry if we do have some undiagnosed ADHD or something that can be treated pharmacologically. Okay, next slide.
Okay, so these are some extra resources that you can use. We have books, websites, and kind of caregiver resources. The Boy with Big Feelings is a great one for littles. Listening to My Body is also a really, really good one. Let's see, and then we have a couple of websites that you can use. I really like the anger management for kids and adults. It's 4 minutes long. You can show this to parents. It's a good one for parents and kids to watch together. I really, really like it. And then there's another one with the Mindful Youth Institute that has some really good books and articles that you can give to parents if they need a little bit extra information. And then the caregivers, Raising Good Humans is an excellent, excellent book. And if I had to pick one book, it would be Raising Good Humans and Raising an Emotional Intelligent Child. That's also good for adults if you have somebody who maybe doesn't emotionally regulate very well. You can apply that to adults too. I've done that in my whenever I was working with crisis situations. So those are two excellent books.
Thank you very much, Dr. Schneider and Elizabeth, for your session today. Now, we have some time for questions and would love to be able to open up for questions. If you do want to unmute yourself and ask your question, that is certainly fine. You may also ask your question in the chat. I do have one question though. Elizabeth, you had shared with me one time there was a link that was available that and it was for resources and it was free, because we did have some questions in the chat about resources that can be used for anger and aggression. If you could send that link to me, if somebody wants that information, I can send that back to them. I can send that to you. So I will put the email address to contact us about a PDF copy of the session, as well as if you have questions about where to locate resources. Any questions?
There was a question earlier in the chat from someone named Tisha. It says, unique situation ask, how do you encourage this in another adult that's matched the aggression energy of the child? The adult becomes triggered themselves and you're the bystander trying to help. What language would you suggest in this approach? I think that's a great question, and often happens a lot. We're thinking about, again, the modeling. One thing that you can introduce is kind of like the cycle of escalation. In the research, it's called like the Patterson coercive cycle. If you kind of type in like a coercive cycle, you can get some great visuals on it. But it's really helping describe how that response is actually escalating the situation rather than helping reduce it, right? So kind of challenging a family like, hey, I'm noticing a lot of, sorry, my language is very littles focused, but a lot of big feelings, a lot of big emotions in the room. Let's break it down a little bit. Let's kind of practice what we want to try, even in the office. So kind of highlighting like, okay, so kiddo started here. And then what was your response? Caregiver. Okay. And then what happened? And kind of challenging caregiver, like how did kiddo respond? Okay. And then kiddo, and having them both realize that their aggressive and externalized reactions are causing the other person to react. With my adolescents, I like to kind of pose like, hey, when we come to the table with our knives up, people are also going to put their knives up. And so we can kind of present that to our caregivers too. I'm like, when we go on the defensive, other people will as well, and try and help them understand how that escalation is both kind of spinning each other out of control, and then how eventually it reinforces behavior. Because what usually happens when a kid and a caregiver are matching each other's energy, right? Either caregiver gives in, so then kid learns, if I get big enough, my caregiver will give in, and then I get whatever I wanted, or I get whatever function I was trying to achieve. Or if kid gets loud enough, then caregiver learns no amount of me yelling is going to work here. I eventually just have to either yell loud enough and it gets kid to hush, so it's reinforced, but not really changing behavior in the long run. Or caregiver eventually gives in and it's all for naught. Now I'm emotionally dysregulated and I didn't achieve what I was trying to do as a caregiver. So kind of bringing that intensity awareness to them. And then also helping them understand that discipline is about teaching our kids, and understanding that when we're yelling, we're not really teaching them how to respond to anger. We're modeling anger for them. So if our goal is to teach our kids how to behave, then we really got to pay attention to how our behaviors are teaching them. And when we're yelling in response to something that we don't like, which is our kiddo misbehaving, then it's teaching our kid that it's okay to yell or hit or externalize when they see something that they don't like. And so kind of drawing that parallel of that, we see, I see what I do, and kind of bringing that to their attention, I think can sometimes help with that click of, oh, okay, maybe I need to change what I'm doing. Elizabeth, any other thoughts on that?
Yeah, as a therapist coming into this, it's one of the other things that I will talk to a parent about is what is your parenting style, and also what was your parents' parenting style? Because if you came from a parent who yelled and that's all they did was communicate, then you coming in as a parent, you're going to regress back to that because that's your first memory of how you take care of a disobedient child is you
Yep.
yell, you get big. That doesn't work. So you as a parent are going to have to reteach themselves, and they can do this through therapy, um, how to change their parenting style, how to change their way of parenting. What do they need to do to be a better parent? And that's huge for parents to understand that, you know what, this was wrong. I need to take a step back and I need to work on myself so that I can model that good behavior to my child so it'll break that cycle, especially if there's trauma or abuse in the background. So
You
that's
know,
something
something
to ask about.
I wanted to add this also, Dr. Schneider and Elizabeth, is that if you're a provider and you've used all your tools in your toolbox, and at this point you're not exactly sure what the next step could be, if you contact CPAN, if you're a primary care provider working with patients under age 23, so 0 through 22, our hubs, all 12 of our hubs across the state of Texas, are here for primary care providers. When you call in, you can speak with somebody like Elizabeth, who's a licensed professional counselor. We have licensed clinical social workers. We have LMSWs. Some of the hubs have psychologists, such as Dr. Schneider. We have psychiatrists. You can speak with those individuals, and all of that is at no cost to you because that is fully funded by the state of Texas. So you're not alone. We are here for you. No call is too small. We really are waiting on the phones for your call. Almost sounds like I'm trying to sell a service. I'm not. What I am, though, is letting you know that we are here for you. And if you're a primary care provider that works with patients who are preconceptual, pregnant, or within 1 year postpartum, we now in Texas have PeriPan, or the Perinatal Psychiatry Access Network. The same exact services that you as a CPAN provider have used are now available for you for patients that are preconceptual, pregnant, or postpartum all the way up through 1 year. And we would love to be able to support you with those services as well. We know that maternal mental health problems are one of the number one reasons for maternal death in the first. In fact, mental health, I believe the stat is the number one reason for death postpartum in that first year is mental health. So we want to support you with your pediatric patients as well as those who are perinatal. Dr. Schneider,